For people living with HIV, illicit drug use, particularly opioids and stimulants, is prevalent, with 11.3% of women living with HIV in Canada reported to have crack cocaine use within the last 3 months. Unfortunately, there is abundant evidence that illicit drug use increases the risk of disease progression, HIV transmission, and mortality, and continues to complicate HIV care and effectiveness of treatment. For people living with HIV, HIV-related stigma intersects with their individualistic social determinants of health, which can result in coping behaviours such as illicit drug use to help combat life's daily stresses. Further, it is important to note that multiple dimensions of the social determinants of health generally co-occur, and although some determinants of illicit drug use are well researched as independent influences on drug addiction, few studies have actually explored the social determinants of health holistically and how it interplays and exacerbates health disparities for people living with HIV. Therefore, Skulley et al.'s 2019 retrospective cohort study, which explores the association of the social determinants of health clusters with drug use amongst women living with HIV, allows for further knowledge and critical understanding to be gained on how to develop and deliver person-centered care from an upstream perspective. Skulley et al.'s retrospective cohort study identifies 12 modifiable social determinants of health clusters, which exacerbates the risk of women living in HIV relying on illicit drug use as coping mechanisms. These include racial discrimination, gender discrimination, enacted HIV stigma, perceived social disport, barriers to access to care, food security, house status, income level, employment status, education, recent sex work involvement, and recent incarceration. These factors increase the risk of suboptimal adherence through limiting access to HIV treatment services and affecting individuals' health-seeking behaviour. The study also determines that illicit drug use in women living with HIV impacts HIV care through interruptions of treatment, which exacerbates health disparities for the population by threatening the benefits accompanied with early HIV treatment initiation and the commitment towards eliminating the HIV pandemic. Overall, the study concluded that the high prevalence of socio-structural adversities amongst women living with HIV corroborates with existing research that women experience substantial social determinants of health vulnerabilities. Further, the results identified discrimination, stigma, and economic hardships as the major overlapping social determinants of health for the high rates of drug abuse for women living with HIV, as the prevalence of self-reported illicit drug use was approximately 7 times higher in women living with HIV who experienced the most social determinants of health adversities than those experiencing no to least adversity. The results are suggestive that by improving modifiable social determinants, only then can the barriers which facilitate health disparities for females living with HIV be eliminated. The results of the study force you to pay attention to the interconnected nature of social and drug use determinants, and therefore encourage that it would be a key priority for policymakers to address this relationship in order to improve HIV medical care through regular assessment of these factors as well as targeted support for women, which, if addressed holistically, may reduce the likelihood of suboptimal HIV clinical outcomes. However, it must be acknowledged that more investigation is required to ensure the health inequalities are addressed with comparable evidence-based research in regards to the interplay of the social determinants of health. Now that we have identified the impacts of the social determinants of health on women living with HIV and their susceptibility to turning to illicit drug use as a coping mechanism, which ultimately exacerbates the likelihood of poorer health outcomes, we must acknowledge the credibility, reliability, and validity of the evidence presented. Firstly, the study identifies that there are 1,422 participants were selected from CHI WOS, a community-based cohort study of women living with HIV residing in the Canadian provinces of British Columbia, Ontario, and Quebec between 2013 and 2015. The study identified their inclusion criteria as greater than 16 years of age and trans-inclusive, but did not disclose any exclusion criteria. The exposure groups were selected from the same population, and there is no reason to believe they differ in their selection except for their exposure status. After 18 months, 170 participants were lost to follow-up, which is sufficient for the aims of the observational study, as they had a retention rate of 88%. However, the authors do not detail reasons of why participants were lost to follow-up, nor did they describe strategies to address incomplete follow-up. Secondly, the study provided detailed explanation of each of the scales utilized to measure each of the exposures, which unlikely to have led to systematic differences, as the scales applied for each of the social determinants of health are well established and used for every participant. The study reflects appropriate internal validity, as trained peer search associators administered each survey through in-person interviews. However, the authors acknowledge that as a base for their measurement tool, they relied on self-reported drug use, which may be subject to social desirability bias. Further, the intro-rater and the inter-rater reliability are solid, as the authors clearly detail the methods used to assess the validation of the data and length of time to follow up in the article. However, non-random sampling of participants may limit the generalizability and interpretation of the findings. Although unmeasured confounding is a source of bias in observational studies, the sensitivity analysis shown then relatively strong unmeasured confounding would be required to nullify the observed associations. Further, the authors identified a number of confounding factors such as age, ethno-racial groups, province, city size, sexual orientation, relationship status, years of living with HIV, art status, have ever been diagnosed with a mental health condition, resilience, any history of child or adult sexual and physical violence, alcohol use, and having been under the care of child protection services. The authors note they use inverse probability weights to account for confounding due to the presence of potentially imbalanced covariant across the social determinants of health clusters, and inverse probability censoring rates to account for prospective selection bias due to potentially non-randomized loss to follow-up. Finally, the study details that social determinants of health clusters were modeled using a multinomial logistic regression using LCA procedure. In conclusion, the authors of the study do express satisfaction with the outcome of the study, and the results do reflect results from similar studies. However, as there is limited knowledge on reviewing the relationship between drug abuse and the social determinants of health holistically with women living in HIV, the evidence must be considered alongside other literature and epidemiological studies. Now that we have determined the credibility, reliability, and validity of the evidence presented, we now must consider the impact the results yield on the future of improving health outcomes for women living with HIV. The results of the study are indicative that drug treatment programs which focus on behavior change interventions may result in limited impact if there is no additional efforts to change the social environments of the drug users. Therefore, the authors suggest that HIV care programs in the future will need to make intentional efforts to ensure that drug users have full access to optimal care by developing evidence-based treatments for drug dependence, including harm reduction strategies which recognize the role of the social determinants of health in impacting overall health outcomes. Further, The study's findings support that the targeted assessment of multiple disruptions and drug use vulnerabilities, which are HIV specific and women centric, have astronomical potential to create a low stigma environment which will allow for these issues to both be assessed and addressed in a holistic manner. The author's suggestions are justifiable as the research conducted extends the limited knowledge on drug use amongst women with HIV. Further, their research contributes to theoretical development through examining the inclusion of detailed individual-level data of current social determinant as leading stressors in the targeted population's daily life. Interestingly, the ideas and concepts raised by Skulley et al. Is transferable to other healthcare settings and models of care as the upstream approach for future policies to implement change from as early as the social determinants of health for an individual's physical, social, and economic environment for any health disparity will inherently and ultimately improve the overall health outcomes of vulnerable populations, lessen the health disparities, and therefore progress the health of the general population.